Okay. My name is Kristin Koshar, and I am here to present professional diversity for the BLD program. And on our agenda today is just a quick introduction, a brief timeline of my education, as well as my career, and then my current job duties, and then a summary with any questions that I could answer for you guys. So my introduction, I was told I should put pictures up. So these are my children. You guys know Elaine. And then, well, I can't point and guess. This is Lydia in the middle, Elaine, and then David and myself. That's outside our house. Lydia is the tallest of all of us. Elaine's the oldest, then followed by David, followed by Lydia. David is also at Michigan State currently, go green. And Lydia is a junior in high school. Nice, good children. And that is my fiance, Jason. We went to Las Vegas a month ago. It's extremely crazy there. It's really expensive, but it was a lot of fun. And then we are a blended family. So these are all of our children together. We have Seth on the end, who is the oldest. And then the little girl is Bryn, his daughter, our grandchild. And then Brooklyn, Lydia, Jackson, Callie, Elaine, and David. So they are 28, 26, 21, 20, 19, 18, and 16. So we go right down the line. And then we do a lot of stuff together. We like to camp. We boat a lot. We play a lot of board games and card games. So here's a picture of us boating and me throwing one of the kids off the tube. I think that was in Kentucky. One of our other games was I would try and hit the tube onto a dead fish, which was great. And then we love to go to concerts. So that is us at the Upheaval Festival in downtown Grand Rapids, which was a fantastic concert series. It was a whole weekend. It was a lot of fun. So those are some of the big things we really like to do. Get out of here. I lost my mouse. I have 3 screens, you guys. So in case you wonder, I lose a mouse sometimes. And then as for retirement goals, I would like to retire at 55 and then go back to actually working on the bench part-time as a bench tech. I used to be a core lab generalist, but since I've taken over the microbiology area, I'm really kind of getting into micro, and I think I might go back into microbiology. So for education, I went to a small school. I graduated with 73 students up north, like right here, called Hesperia. I graduated in 93. When I graduated Aquinas College, I was originally pre-vet. I went to Aquinas for 2 years, kind of jumped into psychology, flipped over into education, thought about physical therapy. So I went to Grand Valley for a year for that. And then I eventually ended up at Ferris State University. I read quite a few Patricia Cornwell novels. If you're not familiar with her, she is into forensic pathology. And that is kind of how I got into the medical technology area. If you're not familiar with the college at Ferris, they are kind of do like a simulation lab along with their classes. And when I was done with my sims, I went and did an internship at Blodgett Hospital, which is now, part of Spectrum Health in Big Grand Rapids. It was really cool. They had a toxicology lab, and you got to do go down into the morgue area and see all of that stuff. So because they were a larger hospital, I got to see more than some of the other students who did internships. So when you're making your intern selections, depending on what all you want to see and where you want to end up, that might be something you want to take a look at, is what those hospitals have to offer you, as well as, what education you're going to gain when you go there. So then I graduated, obviously, with my BS in medical technology, and I got ASCP certified in June. And just a word of, I don't want to say warning, but a word of education or maybe caution is do not wait too long to take your ASCP certification when you graduate. the most knowledge you're ever going to have is when you guys are taking your finals and then applying that in your internship. That is when everything's going to be fresh in your mind and the easiest to take your boards, and you have your highest chances of passing and getting good scores on that. So just, I know some people have waited 6 to 8 months to a year, and then it's really hard because it's like relearning all of that information again. And then right after my internship concluded, I got hired in here at Lakeland in May of 1999, and I've been here ever since. So it's at 24 years. I think it's a great hospital to work at. I love the area. I love Lake Michigan, and I do not see myself leaving anytime soon. So for my career, when I got hired in as a second shift core lab generalist. It took me about maybe four months to get trained. Your training period is going to be the best time, maybe depending, but it's so nice. You train Monday through Friday, day shift, no weekends, no holidays. So it's kind of nice because you're just living the dream job. And then when you get actually working in a hospital, you're working your weekends and holidays. So, but second shift was 2 p.m. to 10:30. I am a second shifter at heart. I would go back to second shift in a heartbeat. Is my favorite shift I've ever worked. I do not like to wake up early. After about a year of being on second shift, I was offered a charge tech position for when our supervisor was not on site. And about maybe a year after that, somebody on day shift retired, and I was able to move into the first shift core lab as a generalist again. So if you're not familiar, just to clarify, a generalist works heme, coag, urine, blood bank, pretty much everything except for microbiology, because at Lakeland we do have all areas, including a full microbiology lab. So microbiology is separated. You don't do gram stains, you don't do blood cultures, you don't do any media setup. That's all done back in microbiology. After I was on day shift for about like 2 or 3 months, I wasn't on days very long, I got offered the shift supervisor position, which I accepted, and that is on second shift. So when you are a shift supervisor, you are over the second and the third shift technical team, and you also help oversee the lab assistant team and a little bit of client services, which they answer telephones, call reportables, call criticals. If the techs can't get a hold of somebody, they just kind of follow up and take care of everything. So shift supervisor also worked the bench 50% of the time. That is probably the favorite position I've ever had. I loved working the bench as well as being in the manager aspect. After I was shift supervisor for about 2 years, I think, I was offered the manager of support services position. The manager of support services is kind of a different branch in our area. It was not as technically geared. It was more kind of like pre-analytical and post-analytical, not so much within the analytical realm. I was over the client services department, which, as I stated, was over, like the telephones and reporting. It was over inpatient and outpatient phlebotomy, and it was also over our courier services. So we have our own couriers who go to all of our outpatient clinics, our different hospitals, and pick up all the specimens, drop reports, drop supplies, and then they come back to the core lab, and that's where everything gets ran. I was manager of support services for probably 7 or 8 years, I think. And then our managers at Niles and Watervliet left, and we kind of merged those management positions into one position, and I took over both of those sites. When I was over Niles and Watervliet, I was over phlebotomy and technical. So it really expanded my knowledge base and allowed me to understand more of the pre-analytical stuff, as well as still maintaining the analytical stuff. When I was at those sites, I also got my technical competencies back and was a bench tech at Niles to help out when there were openings or openings, or like when people called off sick. If they needed help, I was able to fill in for those. And now that I'm kind of talking about this, I feel like I should stop and give a brief structure over what our hospital system is like. We are now part of Corewell Health Systems. We are considered the South region, which was formerly known as Lakeland. So we have our core hospital in St. Joseph, which is a medical center. We offer every service. We are considered a trauma 1 level. ER, we have all the surgicals. We have CCU, a very busy OB. We have a behavioral unit. We have 200 beds within our hospital system and 40 bed ER, I believe. We also have an outpatient service center that sees about 200 patients a day. And we have an oncology laboratory as well that sits within that outpatient service center that only services our oncology clinic patients. We also have 2 sister hospitals. There's one in Niles and one in Watervliet. Those are considered rapid response labs. Rapid response labs only test specimens that come from that facility and our staff. So they only service the ER and the inpatients. If there's an outpatient that has a stat, like if a baby comes in and gets drawn for a neonatal bilirubin and they need those results right away, we would run that at that site. All the other outpatient specimens go up to the core lab in St. Joe. So Niles is a little bit larger than Watervliet, but a lot smaller than St. Joe. I would say they do a third of the work that St. Joe does. They have an OB, they are 2 stories. They have a very small critical care unit. They do have a bariatric unit and a heart center. They are considered a level 2 trauma. And then we have Watervliet, which is an ER and a walk-in clinic. And they also have a post-surge floor, but it's really like a 23-hour hold for outpatient surgeries. And they have a rehab unit, which is kind of more like a nursing home. So that's kind of how all of those fit together. So when I was manager over those 2 sites, I would probably spend 75% of my time at Niles and 25% of my time at Watervliet, just depending on what paperwork needed to be done, what I needed to do with staffing, and what meetings I had on the agenda. And then in January of this year, the manager that was in St. Joe retired. And so I applied for that position. I actually had to interview. It's the first management position I ever had to interview for. I had to create a resume, which was something new for me. I hadn't done one since I got hired in as a core lab generalist. And so I started that in January. And in March or April, the organization started, well, I guess it wasn't really March or April, it might have been May or June. They decided to, for financial stability, cuts. And so we ended up cutting the manager of support services position, and I absorbed some of those responsibilities. So my title changed to manager of laboratory services. So I am now over the courier services, inpatient and outpatient phlebotomy, and all of the technical people that report at St. Joe. So that includes the microbiology department, the core lab, as well as the oncology laboratory. So does that all kind of make sense? I can't see it. Nobody's cameras are on. I can't see anybody's faces. I don't know if anybody has questions. Good? Okay. So I put up next, this is kind of like our laboratory structure to give you guys an idea of all the different positions within an organization that you can do if you want to stay within the technical realm. So you can see the administrative director in the middle there with the blue star. That is my boss. His name is Joe Brown. He is an MLS degree. and he's probably got 10 years, 15 years of experience. He's a great director, has a lot of clinical regulation knowledge. And then we always have a pathologist who is our medical director. And then we have other staff pathologists that help us do, tissues, fine needle biopsies. So we do have a full pathology lab here at St. Joe as well. So then you can see there's 3 different managers. We have the manager of technical services for St. Joe and oncology, which is myself. We have a manager of pathology, and then we have the manager for Niles and Watervliet Laboratory. I have 2 supervisors who report to me, the supervisor of shifts, which is that technical manager or technical supervisor for 2nd and 3rd shift technical. And then there's a supervisor of phlebotomy who is over inpatient and outpatient phlebotomy. I also have 4 technical specialists who report to me. So our technical specialists are kind of like our department coordinators or department leads. So we have a chemistry, heme, blood bank, and micro. So they are the ones who do like assay validations. They score the proficiency testing. They review all the quality control charts. They are the ones, they would be kind of considered your subject matter experts. So when then there are issues or problems or the analyzers go down, that's who people go to when they have questions and need help. And then they come to me if, there's bigger fish to fry or I need to purchase something. And then we have all of our technical staff and phlebotomy staff. That's kind of our structure. So MLSs can be any of these things, and even all the way up to like your COO. Our previous vice president, who was a direct report to Dr. Hamill, his name is Kendall Troyer, and shifts. He is now the over Corewell Health Global. So if you want to escalate within management, you can go as high as you want. I do not want to go any further than a manager. I like being connected to the front line, which is why I've never gone for director or tried to go any higher, because I really like being involved with my personnel and having those one-on-one conversations and doing all that stuff. We've also had technical staff go into infection prevention. We've actually lost a couple, I shouldn't say lost, they merged over. We've had a couple people leave and go into clinical research, and we've had some go into risk management. We've also had 2 people leave and go into the EPIC, which is our medical system, electronic medical records, and start doing like project management for them, supervise different projects, and become leads for implementation of some of the software that they do. So you can go anywhere with this degree, and it just gives a really good background for the knowledge base that is required for all aspects of the hospital. Okay. So duties and responsibilities associated with being in management. It gets a lot more managerial than it does technical, but you need your technical knowledge in order to do performance coaching and corrective action. So I currently have 41 associates that direct report to me. I have about 90 altogether when they roll up with my supervisors. So I am in charge of ensuring that they are paid correctly. I have to do payroll every 2 weeks. Make sure that their PTO, which is their paid time off or vacation time, and I also have to track their attendance record. So when somebody is absent or tardy and they need performance coaching or corrective action due to that, that also falls on me. Along with the performance coaching, I'm sure you all are familiar with like corrected reports. So whenever you result a patient result and it was erroneous and you need to go back and correct it, either to disregard it because it was contaminated, to disregard it because it was a mislabel, to correct it because maybe you did the dilution incorrectly. Those corrected reports all go through, and then they get tallied and put into like your quality data. I am in charge of making sure that those corrected reports are all tallied and reported out, and then following through with the associate if they need some coaching. We try and look at most of our corrective actions as performance opportunities and improvements, not as punitive, but there are times when, like if somebody has 3 patient ID errors, you want to start talking to them about, you really need to start paying attention to your patient name and date of birth, making sure that you're matching your specimen to your screen, to what your analyzer prints out. And, if they continue down that path of having those types of errors, then you need to start usually a corrective action. Occurrence reports are very similar to that. They just kind of follow when there is an error or an issue, and you need to do a lot of investigation to make sure that it was followed up appropriately. A lot of occurrence reports come from QC errors. So like if somebody doesn't follow through appropriately on quality control, so say they have a 2,2-SD error on your coag analyzer. When you have a 2,2-SD, you're supposed to stop your patient testing, get your QC back in under control. If you have to get your QC in by replacing your reagent, then you need to repeat all your patients that were performed since your last QC that was in. And so if somebody does not follow through appropriately with their quality control troubleshooting, then an occurrence report gets written, and it falls to usually myself to follow up with that individual to kind of explain what the appropriate course of action is. And it's when a pattern starts to trend, like if they do it 5 times in a row, then you again would look at like starting corrective action or using a different tool. We have a tool called Learning Tree, which is where you document performance issues and like the improvement opportunities and how they are going to achieve making sure that they are doing what is correct. The same is true with critical result follow-throughs. We have reports that print to make sure that every critical result is called and documented appropriately. We actually have within our system a flag. So whenever we have a critical result, it flags you to document it appropriately, and you can't get out of the system without calling and documenting that critical result appropriately. And that is all CAP standards that you have to follow, or you can get cited from CAP. And it's to make sure that your patient safety is number one and everything's followed through appropriately. We already talked about quality control. So with your direct reports, I have an open door policy. My door is shut right now just because I'm in here, but my door is almost always open so that people come in and talk to me about whatever they need to. One of the biggest things is to make sure that you listen first, take a couple breaths, and then maybe give some feedback. The other thing with feedback and listening is that when there is an issue that you need to follow up with, you usually want to ask them what their perspective is first, instead of saying, hey, I heard you did this. You want to say, hey, I heard there was an issue with this. Can you tell me what happened? That way they are able to give their viewpoint without you being accusatory. And then we are also in charge of annual performance reviews. We call those heart to hearts. We do those once a year. We are a merit-based location. So that means depending on how well you are performing within your job, helps determine what raise you are going to get. And those are all documented in a system. We have a system called Workday, and everything gets documented in that. Next, we have associate and patient satisfaction scores. So associate satisfaction scores are measured on a survey that is pushed out every 3 months. It's called Glint. And we are based, or we get kind of rated based off of how many of our associates participate in the survey and then like what our satisfaction scores are, as well as areas that we've improved on. So like our last Glint survey, I believe I had a 93% participation rate, which was really high. My overall team had a 81%, and our overall ESAT score was 51, which is a little low. We had a lot of feedback around some safety concerns on the floors with sharps containers not getting emptied. So our inpatient supervisor and myself have been working with the floor managers to try and get that resolved. So hopefully that will help improve our scores. Our patient satisfaction scores are measured through an independent source called Press Ganey. You are not supposed to use your own because you can skew your data. The companies really like to see it. The outside source is used for that. So our patient satisfaction scores right now are trending up. We are looking to try and get into the top quartile. Grand Rapids is already in the top quartile, so we are trying to get to where they are at. We are using different methods and trying to change some of our wayfinding in our outpatient sites. So it's a lot of marketing and really digging into your, well, I was gonna say customer/patient comments to see what you can do to improve the location, the speak that your team is using, the comfort level surrounding the area. What other word did I want to use? Oh, just the general atmosphere, I guess, of the area. Some places seem a little cold, and so we're trying to get away from that and using, you know, more comfortable furniture. And we got rid of all of our magazines because we had a lot of negative comments about magazines. They're dirty or torn and just not looking nice. Any questions on any of this? Am I talking too fast? Okay, I got a thumbs up. Other duties and responsibilities when you are a manager have to do with hospital integration. Since I have been in management, we have integrated with the Southwestern Medical Clinics. It was a group of 4 different outpatient clinics housed in Niles, Stevensville, Bridgman, and there's one in St. Joe. There's also another one in Buchanan now. We merged with all of them and pulled them into our system. We've merged with Waterville Elite, and we merged with Spectrum Health in Grand Rapids, and our latest integration is with Beaumont. With each one of those integrations, you have to look at the services that are performed and look at your financials to determine what services make the most sense to keep and where, as well as what duplication of services you want to keep performing. So like for the laboratory, some of them have to stay and some of them should go. The other issue when you have integrations is looking at like your different softwares, the platforms of analyzers that you use, because you want to be as standardized as possible. So right before the Beaumont integration, we were having meetings with Grand Rapids, Spectrum Health, Corewell Health South, West, I think they're West, Corewell Health South, West, one of them, Grand Rapids, to see like what, how they were reporting certain analytes and how we were reporting certain analytes. And that's what compendium reviews are. You look to see what your normal ranges are, what their critical results are, and how you can merge those so that they are as close to the same as possible. And it sounds semi-simple, and it is extremely tedious, and it is very difficult because you are working with a very large group of individuals who have been doing things their way for a certain period of time, and they don't want to change. We don't want to change what we're doing. They don't want to change what they're doing. But you have to figure out a way to get everything into one system, because when your computer systems are all in the same and your patients are flowing back and forth between those sites, you want your results and your trending to all match and be compatible. You don't want results from 2 different analyzers. They're not going to be compatible. They're not going to be the same. That's why you try and get all your testing platforms and software all together and on the same. We were slated to merge into their same electronic medical record, Epic. We're both on Epic, but we're on different instances. We were slated to merge into their Epic and switch our LAS to Beaker in Q3 of 2023. And when we merged with Beaumont, everything got halted, and we've been holding for about 6 months, and we just started compendium reviews again for all 3 sites, with Beaumont, with Grand Rapids, and with us. It's a lot of work. It's something that I've never done before, because it's so much larger than anything else I've ever had to tackle. So it is really kind of, I don't want to say taking me out of my comfort zone, but it is definitely pushing me in a direction that I would never have anticipated doing when I was in the MT program. And then you have to make sure all your procedures are standardized, that, you know, like the way we do our quality data is different from how they do their quality data. And you just want to make sure that everybody's on the same page. It's very interesting to see all the different ways people interpret CAP standards and how people meet those CAP standards. So it's a very interesting aspect, and it's also a very difficult aspect. One other area that I am over that I never in my entire life thought I would be over is invoices and billing. When we changed some things over the last year, we became in charge of our own invoices and billing. So I enter in all our requisitions for the laboratory. I order supplies. I have to input service contracts. I don't negotiate service contracts necessarily. That goes through the legal team, but I work with them to get everything set and in place. And then I have to push it through our finance software to make sure that they get paid, and then set them up so that they get paid on an annual basis. Being in charge of the couriers, I have a monthly, I actually have 2 monthly bills now. I have one monthly bill that is for our gas cards. So each courier vehicle has their own gas card that they use to fill up the vehicle with. And the middle of every month, I get a new invoice for them, and I have to make sure that that gets paid. So I have to go onto that website, pull the invoice out, push it through the software program for finance. And if it does not get paid in time, my courier cards get shut off and my couriers can't get gas. And it has happened 3 or 4 times in the last year. So, and really through no fault of my own, it's just sometimes the system gets bogged down and things don't get paid in the amount of time that they're supposed to. And everything is so automated and email oriented that there's really not even anybody to contact at the gas card company to see if they would reverse the stop payment. So that's happened. We've had service contracts not get paid in a timely fashion. So then when we have an analyzer that breaks down, we cannot get service to come in and take care of the analyzer until we issue a PO in real time to pay for that. So you go to med tech school and you're all analyzers and reagents and very technical and analytical. And then when you get into management, you're dealing with all this financial stuff that you never thought you'd deal with. So I would say invoices and billing take up quite a bit of my time. I have to pay all the Versity, which is our blood bank distribution center. I pay for those, and they are about $250,000 a quarter. So blood is a very expensive commodity. So if you don't, make sure you donate blood. We need it. We're out of ONEX right now. The budget kind of goes back to invoices and billing, making sure that you're paying things correctly, putting stuff into the correct service categories and cost centers, but you're also responsible for any open positions that you have. So I had spoke earlier about how we had to kind of absorb that manager of support services position. COVID has hit a lot of the hospitals very hard. We are in financial areas that we have not been in before. And so we are having to make some cuts that we haven't had to make before. So we were tasked with resolving some FTE issues, and they wanted us to cut, a couple positions. And we were able to attrition those, or kind of absolve them, remove them without anybody really noticing, because it was just an open position and we just removed it from being posted. We were really lucky in that we had an open position that we could just kind of shut down. There were some other departments within the hospital that were not as lucky and actually had to, terminate some people or lay them off, whatever term you want to use. And that's pretty much hospitals across the country right now. The COVID bills just kind of hit in different areas, and we are slowly readjusting to those demands and figuring out how to do that. But that's one of the tough jobs of being a manager, is saying, yeah, you really want this position because it makes life easier, but do you really need it, or can you live without all of it or part of it? So like some of my positions, I just dropped from full-time to part-time. I'm like, I don't think, I could probably lose 2 days a week. So that's one of those where you really have to look at your financials and figure out what is best for the organization while still doing what is best and right for your team. Which leads into recruitment and training. We have a recruiter who does all of our positions for the laboratory. So we meet with him every week to kind of look at our positions, look at, what applicants we have, what we need to do, if we need to try and push things on Facebook or Indeed to up the visibility of those positions. We've added, like sign-on bonuses and things like that to try and increase those. And all of that just kind of falls under some of your managerial duties, because you have to ensure that by adding a sign-on bonus, you are able to meet that somewhere else down the line. And then the training is, you just need to make sure that you stay on top of your training, not your training, your new associate training, as well as your students. We have 4 students typically. We take 1 from IUSB, we take 1 to 2 from Michigan State, we take 1 from Ferris State, and we take 1 from Andrews University. So we meet every week to make sure that our students are on track and don't have any questions or concerns. And we also review our new associates to make sure that their training checklists are in line with where they need to be and that they are following the timeline that we have set in place. If somebody is not, then we adjust their training schedule and, adjust it down the road to make sure that they're not getting pushed too hard, but that they're getting pushed hard enough that they're going to be ready to get on the bench when we say they are. So that one can get kind of difficult, the training aspect, because sometimes you have associates who are a little more shy and timid, and so they aren't always open to saying, hey, I need help with this. So that's why we meet every week, to make sure that we are taking care of them and that they're not falling behind or not getting the help that they need in areas that they have concerns. Regulatory compliance. So we just had our CAP survey at the end of October. You get inspected every other year, and the year that you do not get an inspection, you have to go perform an inspection. So that's for CAP. CLIA, you just have to follow all the CLIA guidelines. Our hospital is also inspected by JCO and CMS, and we also have to follow the MIOSHA guidelines to make sure that all of our safety hazards and healths are met. So I just thought if you guys wanted to see, I listed our deficiency responses so you could kind of see what those look like, maybe. So we have 4 different sites. So this is the very first line is the CAP standard. So that's COM.30300. It's a phase 2 deficiency. Those 4 lines at the top stand for St. Joe, Niles, Oncology, and Watervliet. So the check is in the column for the lab that the deficiency was cited. So the deficiency here was we had a calibrator that did not have an open expiration date. So you guys know everything has to be dated. And it was located in use. And we also had a universal diluent with an open date and no expiration date. So then you're supposed to list your action plan. So we discarded those reagents and made sure that we had the correct open date on stuff. Some things can be corrected on site and others you have 30 days to submit your response. So you can see all the way at the bottom that DRA.11200 was a phase 2, and we got cited for that at all 4 of our locations. The laboratory director is to ensure provision of educational programs. So what we did was we just, well, you can read it. I'm not going to read it for you. I hate it when people do that. So then what you do is when you get your evidence of compliance, you submit that to CAP, and then they say, yep, you're good, or no, you're not. So this last citation, we had, they did not like how we did our competency assessment for like our Cepheid analyzer. If you guys are familiar with Cepheid, it's a molecular analyzer that we use back in micro. It does like, group A's, group B's, CTNGs, COVID, flus. So we had all of that under one test system, but because they had different prep methods to start the test, they all have to have their own competency assessment because they are not standardized. So we had to break each one of those out. So we submitted that into CAP, and they said it was not good enough that we delineated it. We actually needed to show that we had an associate go through the competency itself. So now we have 8 days to have somebody actually go through the competency assessment program and do it, which we'll get done. It's just going to take a little elbow grease. And then you also have to submit your quality data. We submit our quality data to the hospital board, and we also submit it for when the CAP inspectors come, they look at it. So this is kind of like our annual review. This kind of shows everything that we track and trend. So you want to always check your pre-analyticals, your analyticals, and then you have post-analytical stuff that you track and trend. So I'm going to scroll here for a second. So like here's our patient ID errors, which would be a pre-analytical. We sort them by location as well as by month, and then we list what our follow-up was. Some are pre-analytical, some are analytical. Every once in a while you have a post-analytical patient ID error. Those are a little bit more rare. That's usually like when you call something on the wrong patient. So, anything else that I have in here? This graph right here is our blood culture contamination rates. The national standard is below 3%. We are right now currently trying to get under 2%. We do very well with this. We are trialing a system called Kieran. It pulls a little bit of blood off before it and pushes the blood into the blood culture bottles. So that's supposed to help reduce your contamination rate if used appropriately. I'm getting close on time, so I'm just gonna, I kind of already talked about project management. I talked about COVID. One of the other big areas being in management is taking care of customer complaints and doing the investigation. And customer complaints can be anybody from physicians to the nursing managers to patients. And the biggest thing with complaints is, to apologize and just ask what you can do to make sure that the issue is resolved. You can't always fix something, but you can try and get the issue resolved. And sometimes that's, giving them a $20 gift card. Sometimes that's crediting a test. Sometimes they are happy just knowing that you have heard them and that you are following up with the individual that was responsible for the error. And then courier stuff. So this is kind of a weird aspect of my job. I had the couriers when I was manager of support services, and I have just kept them with me every time I've changed management positions. They love me and I love them, so we just kind of stick together. So I have 6 different courier routes for the organization. We are corporatized. courier system, even though they are owned by the laboratory and all the expense comes from the laboratory. We run all the interhospital mail. We run all the specimens. We run all the pharmaceuticals. We run all the surgical supplies. We run all the office supplies. And that's for everything within our area. So I think we have up to 140 different physicians and businesses that we supply and represent, including the Berrien County courts. We do some paperwork runs for them as well. So the couriers go all over the place and are just a wonderful resource for us to have. And I hope we get to keep them forever. I put on here areas of focus. So Lakeland has what they call the 5 C's, which they try to integrate into our entire like standard. So communication, curiosity, courage, compassion, and collaboration. These are just all tools that you can use or should use to try and enhance all aspects of your position. I had a little speech for all of them, but I'm not going to go into it because we're at 5:51 and I want to give people time to ask questions if they have any. So that's it. Does anybody have any questions? And I'll take any. You can ask me how many people I've fired, how often I've had to do discipline, what's the craziest thing I've ever seen.
There's one question.
Sure.
Who do you want to, what somebody read? I'm not good at reading.
We have a question in the chat. The question is, what's your favorite part about your position?
Right now, it's probably getting to like go out and round and help my staff resolve issues. I love to troubleshoot and fix problems. That is like my passion, is to try and make things more efficient. So whenever I can go out and help resolve something, that's what I really love. My other thing that I really like to do is when I get sick of being in my office, I like to go process the blood specimens. We call it stat lab. It's all the specimens that come up from the ER. So you have to receive them and distribute them.
All right, we have another question in the chat. Jillian wants to know the craziest thing that you've ever seen.
The craziest thing I've ever seen. Oh, I had to do a legal urine drug screen one time. When you do a legal urine drug screen, you have to watch the person pee and their hands were handcuffed in front of them. So I had to help pull her pants down. I don't know if that's like the craziest thing I've ever seen, but it's probably one of the craziest things I've ever had to do. We've had a lot of body parts come through the lab. Oh, I do have the craziest thing I've ever seen. I was doing my internship at Blodgett and I was in the micro department, and a patient, for whatever reason, came up into the lab and had like, you know, a bag, and she's like, you know, do you guys test for worms? And we're like, yeah. And she's like, I have a worm coming out of my butt. She's like, we were just like, what? And she like bent over in front of us and was talking about how her butt was itchy and that she had worms coming out of her butt and she could see them in the morning. I was a college student. I just was like, that one kind of threw me off.
Was that actually parasite?
Yeah, it was. We gave her the pinworm paddle.
Ah.
She had pinworms. Yeah.
That didn't come up immediately when somebody asked you that question. That is so funny.
I know. But I mean, like in Blodgett, you're on the second or third floor. You're not even close to a patient area. How she got all the way to the microbiology department, I have no idea. No idea.
All right, we have a couple more questions in the chat. So the next one is, how did you talk to your supervisors about your interest in a promotion or a job change?
So I hate to say this, but all of the positions until the position I am currently in were just offered to me. When this position became available, I talked to my boss and just told him that I, was kind of ready for a job change and thought I would like to be more involved in the technical aspect of things again, because when I was over the rapid response labs, I was not. And so then I submitted my resume and went from there. But the other positions, my other former boss was just kind of like, hey, would you like to do this?
Can I interject here on this? This is probably something that she was thought of for the role because of the work ethic that she had at the bench, attention to detail, a good communicator. So there's always things that you might not be aware that your manager is watching, but they are from afar.
That is true.
Maybe you could talk about why, because I know that the current second shift supervisor, you kind of approached in the same way. So you could maybe say some of the qualities that you looked for in the new second shift supervisor that caused you to.
So we've had our shift supervisor position was open and we had somebody doing a really great job, but she only wanted to work part-time. And so we were kind of searching for somebody else. And we had a tech who took some of the charge tech responsibilities, and she just did a phenomenal job. She rounded with all of the staff. She would round with the lab assistants, she would round with client services, she would round with all of the team to make sure, everybody was taken care of. If anybody had questions, she always stayed and helped. And she was a really good communicator. She always made sure that she sent emails explaining issues or questions so that things could be followed up appropriately. And, attendance records play a huge part. She always showed up. She was always on time. Follow through is huge in the technical realm, making sure that you do what is right and then make sure that the follow through occurs afterwards. If you want a high quality driven laboratory, which is what we have here, you have to make sure that, all of your I's are dotted, your T's are crossed, and that communication occurs across all the boards, all the different areas. Anyway, so we kind of tapped her and we're like, hey, we think you'd be really good for this position. Would you like to maybe trial it for a couple of weeks and see how you would like it? And so she did, and then she ended up applying and now she's doing it.
So we have one more question in the chat. The question is from Michaela. Is it difficult to find a balance between being a leader and a friend to coworkers for you? And is there any advice that you have on the situation?
It is. When I became shift supervisor, I actually quit being friends with a lot of my team. And then, well, maybe not shift supervisor, I would say manager, nails and water blade. But then as I've grown into my other roles, I have found that balance. The thing is to make sure, like even with your work-life balance, you kind of have to have an iron curtain that drops. So when you are at home, you are at home. And even though you might be on call and people might call you with work issues, you need to be focused on your family and your home life when you are at home and not bring your work issues there. But the same is true when you go to work. When you are at work, you need to leave your home life there. You kind of just need to take a breath and separate the two. So like our group of managers right now, we all go out together, I would say every other week, to, kind of unwind and talk and laugh. But that is separate from when we are in our workplace and communicating with each other and communicating within groups. And the thing is, you can be friendly and nice with all of your team, but you are still their boss in the end, and you have to hold them accountable and you have to hold yourself accountable. It doesn't mean you can't be friends with them and do stuff outside of work, but those two lines have to stay in place. You always have to be true to what your job is, and you have to make sure that you are holding yourself accountable and everybody else accountable. I was talking to Dr. B earlier and I said, one of the hard things with this job is making sure that you always do what is right, because what is right is usually not what is easy. Firing people is a terrible, horrible thing because you are ruining somebody's life. But in that moment, not forever, but right then and there, it's not a good thing. But if it's the right thing for the organization and for your team and for your patients, then that's what you have to do. And you can ask Elaine. I'll come to work and I totally forget like what I'm supposed to do for the kids. They'll be like, hey, did you do this? No. Did that answer your question?
Yeah, thank you so much. I really appreciate you taking the time to answer all of our questions. And I think I had thought of mine for you as you were talking, because you're just a very kind person, like coming here and spending your time, but also I can tell how much you care. So thank you so much.
You're welcome.
Do we have any more last minute questions?
I have one question.
Yes.
You mentioned the instrument is down. So if instrument need a service, I guess that's what you said. So if we one knob or more than one knob, however the number, if instrument is completely down for significant amount of time, what's going to happen to specimen at your place?
So what we usually do when we have an analyzer down, it depends on the site. So number one, you make sure you communicate to your ER and your inpatient floors that you have an analyzer down and their results might be delayed. You always want to do that first because, again, communication is crucial. And depending on what it is, like at the core lab, we have backup analyzers. Like at our rapid response labs, we don't always have a backup analyzer. So then what we'll do is, depending on the test, if it's critical, so like something in a comp or a CBC, we will transport it to one of our other laboratories to get tested. If it's a hepatitis or like a thyroid, a cancer antigen, those can hold and wait. So usually what we'll do is we will, stabilize and rack those specimens until our analyzer comes up. If we are on a severely extended downtime where we are going to meet or exceed the stability of that specimen, you either have to recollect all those specimens, which you really don't want to do, or you call your reference laboratory and you send them to the reference laboratory. That's only happened once or twice.
Oh, hopefully not so often, I guess.
Yeah, we did have a severe computer downtime, probably back in 2000.
No, there was one.
It wasn't that one. This was like 4 days long. We didn't have a computer system.
Oh,
that was terrible. That's one of the worst things I think I've ever lived through in my entire life. Everything was manually resulted because you held all your outpatient specimens until we got to the point where we couldn't hold them anymore. And then you had to run them and you had to put everything on downtime forms or paper forms and issue those out. I think with all of that, we missed 2 critical results. No patient harm, but we still missed critical results.
Oh. Huh. I know its time is the kind of past, but I have one last question. I'm so sorry.
You're all right.
I don't know. You talked about the bidding, but I wasn't sure you meant the bidding for the, if you are involved in if a patient doesn't pay for the testing. Is that you are part of it, or is other person handle it?
So patient billing falls under like finance, not necessarily under me. Where I might come in as if a patient calls and complains because they had a test done that they didn't want, then I might credit the testing. And I actually will go into the patient chart and credit the testing myself, or I'll send the email. So we did have one instance where, and this was terrible. We really are a great laboratory, but you have 1 or 2 bad things that happen, they stick with you. We had resulted a specimen in error, and the patient ended up going to the ER for the critical test. And when they got drawn at that hospital, the results were normal. We pulled the specimen, we looked at everything. It came from the physician office. So there could have been some pre-analytical error that we weren't aware of. But to resolve the situation and make it correct, we had to correct our results and disregard them and then credit that testing. But we also had to talk to the legal team, or I had to talk to the legal team and work with finance so that ER bill got credited. So we covered the entire ER bill for that patient. So that's why I'm saying, like, there's all these weird areas you get into that you never thought you would fall into.
That I was just curious, just if patient doesn't pay, what's going to happen? But that was even like something I did not think about. Well, thank you.
Yeah, patient billing goes to financial counseling.
Wow.
I don't really deal with that. And like I said, unless somebody calls me directly and has a complaint about something, then we might either, credit the entire thing or just credit like the specimen collection fee.
So that seems like, after sharing your story, seems like a little problem.
That was a bad one.
Yeah.
That's why I remember. I've only ever had to do that once, but that really stuck out.
Yeah, that once, yeah. Wow.
Before you guys in the technical area, just like I have two big stories. One, when I was a second shift tech, I found hairy cell leukemia in a pediatric patient, which was very heartbreaking, but I found it really early. So, and then what was the other one? Oh, we called her critical hemoglobin on a kid. He'd had a tonsillectomy, and the contact numbers that we had, went nowhere. So we ended up calling the police, and they ended up going to that kid's house and getting him and taking him to the ER. He was bleeding down his throat.
Oh, wow.
So we save lives.
Next semester, we are going to make t-shirts. It's one of the students come up with this design. It said, what was the t-shirts design, Elaine?
I think it says, I'll probably save your life one day. You're welcome. It's something like that.
Yes.
So that's the next semester t-shirts design.
See, we do.
Thank you.
Thank
All right.
you.
Any more questions? So thank you for speaking.